Now that we've covered an overview of critical thinking and clinical decision making that we'll dive deeper into in later episodes, how do we actually prepare for these code blue rapid response, these emergent events as we go forward? This is how you lay the foundation for the soft skills and development that we're doing now. Being prepared for any situation may sound a bit scoutish, but there's a reason that being prepared works. Having taken the time, when you have the time to think about it, gives you the ability to think through the multiple scenarios and what could go wrong, what could go right. And that foundation allows you to have the confidence in those high pressure, fast paced situations for it to feel a lot more natural and quick, that you do make the right decisions for your patient. So here's just a first surgical case that I took care of. This was my first surgical one that I had as I was training to take these patients from the OR. Everything seemed fine with the patient. They had had a CABG, an aortic valve replacement, a maze procedure done, and very complex in a way, but it's all in the same area. And the doctor that was doing these, just this is how he did these type of procedures. He kind of did like an all or nothing type of thing. So my unit was very used to these type of procedures coming in. And so they got back from the OR. Everything seemed fine. The patient was stable. The BP was a bit low, but the map was okay. But an hour after they arrived, the patient coded. And this was a challenge for me because I didn't think to expect. I mean, we just fixed something. Why should I expect that the patient should code an hour after getting back from the OR, that we just made them better? We coded them for about 15 minutes, got them back. After we got the ROSC, I wrote down what happened. And I went through the rest of my day, and as I remembered things, I filled them in. And I was trying to identify the knowledge gaps that I had, because I just felt like I didn't understand why this happened. And my preceptor's like, oh, this happens from time to time, but you'll eventually get the hold of it. And like I've mentioned before, that is why we're here. That mentality never sat right with me. And I look back on the situation and realize how they got there. And the research that I did, I found that the internal pacing wires had failed. And the best course of action going forward would have been to reestablish pacing, and our code time would have drastically gotten reduced if we had just put a transcutaneous pacer on and then put a temporary pacer that was floated in through the IVC and into the right ventricle. But I didn't know that until after the fact. And that's where being prepared, I mean, if I would have been a little bit more of how I had the mentality for all my other patients, it's like, how could this go wrong? But I was just naive in the fact that I thought, oh, we're fixing something, and what could possibly go wrong probably wouldn't. So I didn't have the time to focus on that, but I really should have. So we've all heard from our preceptors and teachers that we will find our own process and our own clinical workflow as we go throughout our day. And this is where having a strategy about how you prepare and how you deliver upon that clinical workflow will suit you best. So combining what you know with what is happening with your patients, using a type of visualization to develop a strategy can open your eyes to the virtual experience gain that you can get. And it starts with knowing why your patient is there. Whether they got transferred to you, whether they had a surgery, whether you work in the ER and they presented, you should know the main reason why they're there. So knowing why they're there, now you're able to build off of that and start developing the strategy about what could go wrong, what could happen if they're slowly decompensating, what could happen if it's all of a sudden, what are the data points that I need to watch out for to know that this patient is going to code on me. Does something in their history complicate the reason? And we'll have a little sidebar here, and it's like you can look in your chart, you can ask the patient. Typically, unless they've done this a bunch of times, they're not going to be super good historians, or they're not going to think that, why should I tell you about this one thing that happened quite a few years ago? It doesn't seem related to why I'm here now. So if I came in with shortness of breath, why should I tell you that I had a stroke 2 years ago? It's like something like that. And as you start gaining your experience or virtual experiences, and like I alluded to in the previous lesson, is that the real art to getting better is rethinking your situations. If you had a patient that you went through the entire day and they were fine, well, rethink it in a way of they didn't, and you were running around saving their life the entire day. Like, what areas could you improve on your workflow, on the way that you prepare, on the way that you're able to handle that declining patient with a perfectly stable patient? And even though I'm telling you this now, as I've told many of my students before, you will have a moment in your career that will be eye-opening and will shift your clinical practice. And the next real life event that we're going to do on the next page is that. And I'll preface that in the way that the patient I'm about to tell you about, it was a pretty bad outcome for them. But I had 2 assignments that day in the ICU. But I don't remember being in that other patient's room for more than a total of like an hour out of the entire day, just because that one patient had all my attention. So this patient was had a TVAR, which is a trans endovascular aortic repair, which was in their descending aorta. And they were 3 days post-op at this time. So they were outside of that post acute operational window. And what was very unique about this patient is that they had a history of leg weakness. And one of the, complications to a TVAR procedure, depending on the area that they place it, is that there could be a compression of the capillary bed that and arteries are going to the nerve endings that give you the strength to, or give you the signals to actually like stand and walk and do those type of things. And typically they place a lumbar drain for monitoring during that, but he had, like multiple attempts. The anesthesia couldn't place it. So they decided to just forego that and continue with this. And so it was 4 hours after my day shift had started, and he started complaining of shortness of breath. So I told the resident and the attending that he was feeling short of breath, and they said, okay, well, we're about to round on him, so we'll be right over there. And I went back in and I tried to get him to sit up, just to have a better airway, and he just flopped back into the bed. And I just thought, I was like, okay, he has a history of leg weakness, but this doesn't seem right. And I asked him, I was like, so, and I tried to explore more of his leg weakness history, and turns to find out, I mean, he was able to walk around with a walker, do those type of things. It just, he got tired over time. And no one had told me that in report, that it wasn't as severe as it's sounding now. So I go back and I'm like, okay, you guys need to come see this patient now. And we go back in there. We ended up intubating the patient, placing the lumbar drain. I took him to MRI. I took him to CT scan. I did all these things. We had to place a second lumbar drain because in MRI, the tubing came out of the back and everything. So we had to place a second one when I got back. And my room looked like a disaster. And a tornado went through there just because we had done so many things for this patient so quickly. And the thing that I remember most about this was that he wasn't on any medications to elevate his blood pressure to help perfuse that spinal cord region and everything. So the doctor told me, okay, we placed an order, and we had pharmacists on the unit, and I told him, hey, I need this pretty soon, it's like that kind of stuff. And the doctor came back around, heard me say that, and he goes, no, you need to tell them you need this now. They need to get the medication. You need to put a lot more urgency behind this because this patient needs it. And I just remember thinking, I was like, wow, like I did not approach this in the right manner. I tried to think of that. I was like approaching it in somewhat of an urgent manner, but I was not trying to be a burden on other people, but I needed to stick up for my patient in that situation and be a little more bossy and in a sense, and not so much demanding, but just be like, hey, I need this for my patient. I need this right now. I need to get the pharmacist to give me that medication so that that patient can at least start to have better perfusion of his spinal cord region. And it's just the way that, and we'll talk about this in later lessons, is just like the way that I communicate now has changed due to this patient, and having the right urgency and the right words around how I communicate with other staff, whether it's a pharmacist or a tech or other nurses, to get the job done and get this patient's hopefully from coding instead of to prevent it instead of actually coding. And some of the key takeaways that I'm going to tell you about here is that the preparation, I mean, you'll do a little bit at the beginning of your shift and everything, but there's different types of preparation for different situations. Like you can't say, okay, let's pause, let's prepare to do this code. Like you just have to do it, but you can prepare mentally and physically and understand your clinical decision making leading up to those codes and have a generalized pathway that you would go. But you have to prepare at the beginning of your shift saying, okay, this patient has this history. I have to have this strategy. If I see these data points, I have to do these things, and kind of visualize and just mentally prepare for if those things go wrong. Just to have that already done so that you're not scrambling in the moment. And I found that when you do this and you're trying to predict what's going to go wrong with your patient, you can find where your knowledge base is, and then you can find where those gaps are so that you can become better planned and have a better approach to your clinical decision making and your clinical practice. So the best way to seem like you know what you're doing is to stay calm and collected during a code, but that comes with preparation. That comes with knowing where you stand and your knowledge and your gaps and where you're at, and having the preparation, having the strategy, having those things, that foundation laid, will give you that calm, collected, assertive clinical decision making in the moments. Next, we're going to dive a lot deeper into the analytical thinking and the problem solving so that we can build a more robust foundation in that area.